Create the algorithm must be trained. But trained from who? Who is behind this algorithm? If I have a 25 years old guy here, very good computer engineer, I can tell him how to do it. But if Zoom come here and say something to this guy, he will do as well. So thinking, who is behind the algorithm? Therefore, I like this phrase from our professor. This is so beautiful. Our approaches in diagnosis and therapy must be less structure-oriented and more dominated by dynamics in function. So everything that gives you some perspective of your patient, this is very limited. So we need to study our patient in real motion. To finish our debate, the computer being inside is so difficult to. Professor Sato says to us, inclusion must be treated with principles and not be treated with techniques. I learned from him. He said this so many times. I took this picture exactly 10 years ago. Exactly 10 years ago. And I am so thankful from them for changing my perspective, for changing my way of observing patients and learning a lot about diagnosis. How to see the patient in motion. So thanks a lot, Professor Sato, because I like to say thank you and people still alive. Professor Slavicek is not here anymore, but I told him many times, thank you. So, to conclude, just to give you a little idea, who's this man here on the stage? This guy is a giant. He's so humble, so simple man. But his brain is so big. And I am so happy to have you here, Professor. I'm wonderful guy. I just lined up a little bit here, but certainly millions of other things you did. I don't want to commit a mistake to forget something. I just put a little bit here. Okay? Just a little bit. So I hope you guys can take advantage of this 2 days with him. So I like to do this little debate so you guys can see his ideas on the future. So my final question, Professor, is something like this. What about the future? What can we say for the young people? They are just starting in orthodontics or a few years in ortho or prosto or in dentistry. What is the advice you could give to these people to be good in the future?
Well, I'm now very happy to hear these young people faces. I strongly feel this country in the future promising for the young people. orthodontics in Vietnam. Therefore, I like to question always use watch carefully to find a way, correct way, not not the wrong way. Please find which is the most reasonable, correct idea and approach. This is you should be careful to go directly right way. Then Japan is too late.
Too late already, yeah? United States is too late. But you are young, you can be the top in dentistry very quickly. And United States is too late, Japan is too late, Brazil is still okay, but very Americanized. Take advantage. Do not be exposed to this old mentality and be open-minded. Do you want to switch the computers on? Please. Now Professor can start. So thank you guys for this little introduction. Thank you very much. Then you put your computer.
Vâng, như vậy là chúng ta đã hết tạm thời hết một cái phần opening discussion của thầy Sato và thầy Nelson Oman. Trong khi chờ đợi set up một chút thì thầy cũng có chúng tôi cũng set up lại cái sân khấu một tí, chỗ ngồi thầy xuống dưới, vì cũng xin nói với các anh chị là thầy Sato năm nay cũng suýt soát 80 rồi, có tuổi, sức khỏe không được tốt lắm, cho nên là ban tổ chức cũng thực sự là cũng chỉ mong là đây vẫn muốn là thầy sang đây một lần, ít nhất là như thế. Và thầy thì có tuổi cho nên sức khỏe cũng không khỏe lắm, cho nên đôi khi thầy lecture thầy có thể đôi khi phải ngồi và cũng tuổi cao cho nên đôi khi cũng phải chạy sang anh William Cường một tí. Đấy, trong khi mà trong lúc chờ đợi, trong lúc là gọi là đôi khi cần thiết như thế, cho nên là rất là mong các hội thảo viên hết sức thông cảm. Vì đây là một cái chúng tôi cũng mới được biết được thôi đấy. Dạ vâng, thì chúng ta chờ một chút. Dạ vâng.
We know how develop this kind of molecule. What is the real problem? Already I know. Therefore, if you eliminate this problem, very okay. The purpose of the course is 2 days. I'd like to talk about you must understand and development of malnutrition and treatment planning based on solid diagnosis. And actually, after treatment of malnutrition, avoiding surgery and the moral extraction. I don't know here how many percentage of extraction in molar. No extraction. I don't know, but about the surgery. Anyway, I think 40 years ago, I stopped to use traditional concept, traditional treatment approach, and stop premolar extraction, stop surgery, and also same time I gave up to use extra oral force like a hepatia, ginger, many face masks. I really don't like the expansion. Yeah, anyway, I will talk this subject, but okay. So, yeah, early treatment, I think this is very, very important, but this time I have not enough time to talk. And anyway, the malnutrition treatment I will talk about is anyway, no extraction, moral, physical intervention can stop and extraordinary force. And too long also don't take treatment time. Too long. 3 years, 4 years, 5 years, also treatment. I believe 1 year. 1 year treatment time could be. Therefore, I always say within 1 year. But of course, some cases, in difficult case situation, then sometimes take 1.5 years, 1.5 years. But 2 years too long. Right? Why laughing? Because patient, also don't stay to the patient. No, after learning the elastic this way, that way, do this, that. This is the 1 year. Patient must be patient. This is very fun. If the treatment time is longer, patient tired, no cooperation, this is right. Why? Yes. Okay, and currently, very increasing the malnutrition with CM joint dysfunction case. This is, also our subject. Only orthodontists take care of this kind of case. Of course, this dentist is they also get beam approach, but also don't this. Most responsible them. This is also so first of all, skeletal clustering molecules. Very important. Why did this happen? We have to know mechanisms to develop this kind of molecule. Otherwise, of course, we cannot prevent malformations, not treat. Therefore, in a conventional orthodontic, never explain the etiology of the malformation. Well, just genetic background or something, this kind of experience. Your school, university professor can teach how to develop malformations. You learn? Okay, this is the kind of etiology I like to talk. Then, of course, the observation of the so-called relapse or unsuccessful case. Once again, I graduated from dental school, then started studying orthodontics. 10 years, I learned operational techniques and idea, treat patients, but no successful result. Many, especially class 2, class 3, can be opened by the case. Many results. Do you have experience to have results? So, let me show you. 10 years later, it is 1980, in my hand, 30, 40 cases which are not successful, just cases, many cases. Then I decided, oh, this kind of, I got a dental license, but this is not my job. I wanted to quit this job. No, impossible. I strongly believe at that time. But one thing, hey, why did I? Then I have a material here. Therefore, I started kind of research. Okay. For example, very simple. This kind of situation, modern national and little open tendency, many gaps here. Hey, 2 years after treatment, then I got this kind of result. 2 years. Why 2 years? Anyway. Okay, then debonding, I was happy. Half a year later, patients return to the clinic with this kind of occlusion. Then everybody says this is relapse. This is relapse, maybe genetic background, or that time late growth. Crazy idea. But if I put this piece mandible or back, because this is a hand articulated cut, therefore, easily mandible go back, forth. This is pretty good. Of course, not perfect, but if I manually position the mandible very close to here. Therefore, this is not the direct. Mandible adapts to new position. Okay? Then I was before and after this here and here, I superimpose the cephalogram. You can see here. Mandible come forward. This is growth, something abnormal growth. Then, especially, this is a occlusal plane. This occlusal plane change only half a year, change like this. Here. Why occlusal plane this much rapidly? Something, this one is something wrong. But another case I want. I will show you a couple of cases. Okay? The case where the orthodontic treatment was extremely difficult. Because, for example, this case, orthodontic treatment started at 10 years old. Okay? Here, this is the original anterior crossbite situation. Then we use many appliances, intraoral appliance, and finally edgewise bracket. This up to 15 years, we continue to treat, but still it's mandible comes forward. The occlusal plane here to change more flat occlusal plane. At that time, usually for conventional treatment approach, we use for the class 3 and 3. This is one of the more 6 years molar eruption, this much here increasing factor dimension. Okay, this case, 10 years old up to 16 years old, 60 years later. But this simple anterior crossbite originally, but same, no improvement. Why? The mandible come forward, and at that time, this occlusal plane dropped. This is also 9 years old. We started this anterior crossbite correction, but 6 years we get no improvement. See, occlusal plane. All these approach, I found maybe this vascular dimension and user can run. This is the sound syndrome I found. Then I started some research about the user friend. Okay. But before that, we will talk about the evolutionary background to develop malocclusion in Homo sapiens. Okay. We are long time ago, something 4-5 million years ago, our posture like this. We are four-pedal being, right? And posture like this. Craniofacial structure or complex this way. Then slowly changing our body posture, we are trying to apply this way. Okay. Then every time, craniofacial complex also changes. So very much applied. Therefore, our face is changed. Very much flat, straight face. That means our ontogenic growth and development, our face is mainly vertical growth, not anthroposophic. Okay, like this. Here, newborn baby. This is a start. Here. How much increase the vertical growth? Very much. So, in Homo sapiens, our face is mainly, of course, a little bit of forward, anterior-posterior dimension also increase, but more change vertical height, vertical distance. This is clear. This is not necessary to prove. Of course, actually, during the evolutionary process is happening. No doubt. Okay. So, the newborn baby, something like this. Big green cake. 5 years old, increase, lower face, this much increase. Faster dimension increase, what happened in the lower zone? It's very difficult to bite it. Yes. Therefore, in our faith, Homo sapiens, our faith changed a lot. And now we have wide variation of our facial features. Like this here, we have three here, we have two face, one side, a big variation. Therefore, for me, malocclusion, skeletal malocclusion is not malocclusion. This is just variation of our face. But if you look at something primate, this kind of animal, their face is always same type of the thing. No variation. Right? The only the human we got this kind of variation. Then we also notice that, oh, this is a skeletal class 3 and skeletal class 2 and the variation. This is structured data, so European people, the Austrian people, so territory, no, majority, 52% plus 2. Plus 2 is a microism. More than half of population that plus 2 territory is. This is normal. Japanese data plus 2, something like 40%. That's too many. This kind of variation. So, if you look at the primate curve, this is a breakage, and this is Bayesian, Bayesian, this kind of line. We call this angle cranial angle. Right? Cranial angle is something very close to 180 degrees. Most because the foramen magnum posterior like this. Therefore, here the foramen magnum here and the maxillary complex grows forward downward this way. It was almost perpendicular to the anterior cranial plate and increase very much vertical dimension. This growth is very rapid. So if newborn primate baby, immediately they got almost adult type of face or color. Therefore, increase this one. This is very much. Through the frame, very well. This is the primate. If you compare our skull is bending here, here upright. Therefore, the cranial angle here, the average 125. Very much bending. So, and growth direction of maxillary complex is so much forward, mainly downward direction. Okay. And newborn, I will show you later, but newborn baby is optical frame very steep. This much. Therefore, we have to start not enough vertical dimension and during the growth, slowly increasing more area of the vertical dimension. Foramen magnum, we are bracket, therefore downward. This kind of vertical dimension increasing. This is human. Then this is, I try to show you a newborn baby. Okay, they are under the prayer 75. use elastic, but maybe further play here. This occlusal plane goes through the condyle. It is condyle joint and occlusion, same line. Right? This is changing, growing, close reduction, increase reduction, and lower reduction, alveolar bone growth. Then, slowly increase structural dimension here. Therefore, occlusal plane a little bit down, posteriorly down. Right posteriorly down. Can you understand? Now, the increase, this is we call DPO, distance plane of occlusion. So that means the condyle and occlusal plane, this distance, rolling, increase. We are now permanent 6 years more after more increase, more flat occlusal plane. Then finally, permanent distance. So that time this much increase. Because this distance is very much correlated with occlusal plane bending like this. This is we call the curve of speed. This distance and the curve of speed, this is very nicely correlated. About 25 years ago, French guy O3 published one paper. Nice correlation between TPO distance, radius of curve. Okay, then in my department, we have so-called growth summit. It's a Japanese kids growing every year, once a year. We took referral impression, panoramic, all these data. This is the growth sample. So, in the growth sample, then one of the normally growing subject, here, 6 years old up to 15 years old, we took, I made 2.4. Okay? You see carefully, if you compare anterior teeth, properties here, and the molar, first molar, when it is come down, molar is more down than anterior teeth. Therefore, occlusal plane, posterior part is slowly down. So, let's see here. And here. If molar is down, what happened? Occlusion. Usually, it's also noticed, say, open by. Here, what happened? For example, this mandibular plane angle. Front root horizontal plane and the mandibular plane, this angle, if you measure, increase or decrease. normal growth. Yes, normal growth. Therefore, not this. Okay. Yeah, therefore, increase faster momentum here, but the mantra angle is decreased. Increase vertical mantle, rotate forward, then close and take a back. Just therefore increase smaller area, but the flexion is a little bit open. But pretty soon, mantle will rotate forward, therefore not open to the body. Okay. This is a very important principle. You can use this principle in your orthodontic. Okay? Don't forget this. Good. Vertical growth. And the mandibular rotation, okay. Everybody knows this. Therefore, I at that time, all non-unsuccessful drug-free treatment. So many cases. Therefore, I started closer pain and mandibular growth at this kind of research. Yeah, I published maybe 7 or 8 papers at that time. But that time, one day, I attended the AAO meeting, American Association for Orthodontics. Then I did this kind of graphene development. This is very, very important to understand. Then I presented this kind of poster presentation, but American orthodontists came. Then they said, "Oh, Dr. Sato, no, this is your problem. In the United States, we have no this kind of problem." Yeah. There. Anyway, we can also orthodontists most interested in the development of mandibular. But later, I think also using Caucasian sample, then I did 10 research. No different. Japanese, Caucasian, European people. Okay, then I looked for previously published books and paper, all this, Richardson's data, many data. Then I said, what? All those previously published data, so same. I show you one data. This is published by Matthias, England guy, published this book. All the growing data. I took from this book. Okay. Front cruiser plane. So cruiser plane and front this and mandibular triangle, and you can see occlusal plane from 4 years old. This is a longitudinal growth sample from 4 years old up to 20 years old. We continuously graph mandibular plane. And okay, this is a indicating increasing factor dimension here. Then mandibular flare angle, what happened? All these data show mandibular flare angle decrease. Okay, then one more measurement. What happened? The point A, B, upper and lower jaw connected line, AB and the occlusal plane. This is called no change. Always 90 degrees. This is European, Japanese, United States data. That means, okay, occlusal plane continuously flattening, and the mandibular plane angle is mandibular plane angle rotated this way, therefore angle is decreased. This one, and very much correlated. At the same time, ABOP, occlusal plane is changing, but AB and occlusal plane always keep 90 degrees. That means mandible same time moves forward. Therefore, if occlusal plane factor dimension increase, occlusal plane flattening, mandible will react by rotation. Therefore, same time mandible come forward. Okay? Slowly mandible come forward. This is principle of facial growth, mandibular growth. Okay. Yeah, this is my data. Japanese people, occlusal plane flattening, same time mandibular plane angle increasing, and same time parietal plane and the AB plane, which I measured it. So mandible will slowly go forward. Therefore, this angle is increased. Again, factor dimension increase, occlusal plane flattening, then mandible can grow forward. It's clear. Because this is very, very important. Increase vertical dimension, deal with the mandible open, but we are speaking one, right? Speaking and eating, that kind of function. We have look like a primate, here we have a very nice muscle system. Always we are closing. All this muscle system is working as a closing muscle, not to close. Yes. Well, maybe you know, a long time ago, Björk presented many paper published about the mandibular rotation. Yeah. So, anyway, in his data showing this kind of very small implant here, stable part of the mandible and the upper jaw. Then measure the mandibular rotation. And many paper published and mandible rotate like this. Therefore, condyle, condyle growth is almost vertical growth. This is long time ago, 1954. Already published this kind of paper. So, mandibular rotation. Okay. He asked me, another time has come to do short break. Coffee break? How 10 minutes? Only 10 minutes. You don't want 15 minutes? No, up to you. 10 minutes. Usually, United States, always coffee break. Notes, published many papers about mandibular rotation. Okay. Like this. Okay. Yes. Okay. The Björk showed nicely this kind of mandibular rotation. Condyle growth, maybe the basket growth. I took from his paper, he presented 20 cases in this paper. Okay, how mandibular growth. Then I took from his paper and this paper. This is currently 2005. So this guy, Brother, he published, he checked the main Björk's explanation is correct or not. If you check using the CDCC data, then same. This kind of molar elastom and the condyle almost flat growth. This is possible.
Bakery hack.
Then the mandible rotate this way. Okay. Therefore, he proves Björk's observation is correct. Yeah. So then I took his data. He showed this way, condyle growing this way, 20 cases. But what this means? Not so much growth. But almost whatever the case is. Anyway, the vertically grow over the time, right? Then I try to divide it into different groups, different morphism groups. Okay? See, this is a class 1. Yeah, on the row is like this. Vertically. This is class 3. Class 3, higher case and lower case. The higher case almost the same, same as class 1. Same amount, same direction on the is growing. Everybody talked about class 3 gets more condyle growth. No, the same. No difference. Class 2 grow higher and lower case. Yes. Class 2 lower case more growth than class 1. But the direction is a little bit go forward this way. This is because mandibule is rotates low. Yeah? But this group, now this is a big problem. Class 2 higher case, very much limited on the growth. Because later, maybe tomorrow, I will explain about this group. This is a problem, growing problem. Yeah, I mean, very strong compression. Compression, that means overloading is good. This is a high angle plus 2. But anyway, something like this. Not so plus 3 people, not so much growth of the contact. Leakage from Dynamo also show that nicely. The mandibule is rotated this way, and occlusal plane, this is the lower occlusal plane is changed like this. Then mandibule rotate, therefore the for example, condyle is grow like this. Yeah. And the Ricketts explained this. This kind of rotation is necessary to grow the mandibule. Because rotate when lower border of the mandibule. This is a bone absorption here. Then bone growth, alveolar bone growth here. So, then mandibular rotation possible. Ricketts explained one of the proofs of lower border of the mandibule dissolved after mandibular extension. If you see here, this is a very interesting case. Still, 7, 8 years old, the growing patient. See, here, 6 years more are already after. 7, 8. This side, this is 6 years more. This is 6 years more ankylosed. Ankylosed, that means cannot allow. Stay, same position. Right? Then, pretty soon, if you observe carefully, here, roots are growing, and lower border of the mandibule is dissolved here. Therefore, pretty soon this root affects export outside or bone. Because bone is continuously dissolved. I have another more here. This is also same type of case. This growing teeth, 6 years old. Mora already erupted. But this one ungrowth. The roots growing almost the cortical bones here. And these roots will be exposed. This is one of the evidence. Mandible grow and lower border of the mandible dissolved. Okay? Then one paper we published, how much mandible rotate in normally growing cases. Right? Still, I'm talking about the normal growing subject, not class 3, not open by. See, we try to measure the mandibular rotation about 10 years growth, 10 degrees, class 1 or class 1, class 2, class 3, but anyway, the class 1 case, 10 years, 10 degree mandibular rotation. That means per year, 1 degree. Not so much, but slowly rotate. Okay? And upper occlusal plane, lower occlusal plane, 4 degrees rotate. That DPO growth is 46, 47 millimeter, something. Yeah, therefore I like to show you this. Mandibular rotation is 10 degree. Lower occlusal plane for upper occlusal plane 4 degree. Increase or change occlusal plane inclination. Then interestingly, okay. If you see carefully, lower incisor eruption, rickets also show nicely same way. Okay. This tooth eruption, but not erupt straight. Slowly, lower front teeth are inclined forward this way. Right? Therefore, for example, 6 years old patient, lower front, we have some clouding. All inside are erupted, but the clouding. But if you observe carefully, slowly, this clouding situation disappears. Why? Because lower front teeth flaring forward, then aligned nicely. But was vertically growing. But if you compare 7 years old growing subject after the finish means the permanent dentition completed. At that time, lower incisor is flaring so much. But if you see or cephalometric measurement, that will show this flaring out. Right? same angle because, okay, lower front teeth. We try to measure 10 years of growth, 11.2 degrees flaring out. But okay, mandibule rotated 10 degrees. Therefore, looks this lower incisor standing same position. If I talk this 2 days and open bite, class 3, class 2, always I got the question, oh, if you have a grounding case, how to control grounding? Yeah, very good. They increase vertical dimension. The mandible rotated, right? Yeah. 30 years ago, I presented this idea in Japanese Orthodontic Society meeting. Then I strongly say, don't remove premolar. Everybody said, oh, if you not extract premolar, everything flaring out. This is not patient aesthetic, the subject aesthetic problem we cannot solve. They are not to think about mandibular rotation. But please keep in mind this. Very, very important. Okay. So, human baby, newborn human baby, craniofacial complex, like that. Okay. Already, neurocranium completed 60% because brain is growing very rapidly. Therefore, already 60% finished the growth. Then delivery, if growing too much, therefore, the mother cannot deliver the baby outside. Therefore, this kind of situation is newborn baby. But if you look at here, cranial facial complex, this part, because the visceral cranium, this part only 30%. Yeah? Therefore, if you see newborn baby, their mandible is very small. Then, very short, skeletally pretty severe class 2. If you compare the upper jaw and the lower jaw, one is very much profound. And this is the situation of the newborn baby. Therefore, this situation, skeletally class 2, fewer vertical dimensions, because dorsal plane and the condyle same level. That means I want to say vertical dimension is 0. This is a starting point. Okay? And steep occlusal plane, because this is a very, if you compare the cranial base, this occlusal plane is very, very steep. It's slowly changing. No DPO. DPO is again distance between occlusal plane and condyle. Here, 0 distance. Anyway, this is a starting point. But finally, after permanent dentition completed, well, as I showed already previously, class 1 something like a half. Yeah, let's say 45%, plus 2, another half, then 10% going plus 3. At the moment, today, our subject is this plus 3. How develop plus 3 multiple subject? Okay, starting point like this, and our baby started like this. Okay? Illustration, then sometime, somewhere, anyway, about half of baby established class 1. But another nearly half stay 45% stay class 2. Okay? You know, in the university, education is, some baby growing to finally class 2 in skeletal relation studies. No. Correct understanding is they fail to establish class 1. Originally class 2. Therefore, they are staying as a class 2. Right? For some reason, we have to find out what is the reason why so many our growing kids stay class 2. Then we can also don't have to supply this missing part. This is our task. Okay, class 2 is next subject. Then 10% jump to class 3. Actually, all these growing processes is the adaptation of the mind. I showed very change of user plane, vertical dimension of the molar area, increasing bundle, rotate, and comes forward. This is adaptation of the mandible. We can control. Okay? So, please understand this. Maybe yesterday afternoon, I like to talk about the class 2, but these individuals who are paid to become class 1, maybe this is crucial plane. Crucial plane something wrong. Therefore, stay class. In this case, we call the posterior crucial plane. This is a very steep, this kind of situation, very strong muscle pull force applied to the fonder or joint. Therefore, so many people suffer, make a problem with the joint. Okay, but this is later. Okay, why class 2? Why open right? This is very simple. Very simple. Okay. This is normally growing kid. So this I saw this increasing, changing of the trend, under rotation, forward. That I explained it. But this is class 3 subject. In my department, we have bacteria, growth sample, and some cases growing as a graph tree skeleton. Same way, I made the every year take Peppergram 2.0 feet here. How much? What do you think? This occlusal plane change or molar particle dimension increase this much. Once again, this is a normally growing target. See this much. You should observe carefully the redeveloping growing field. So this much big amount of increasing particle dimension and the flattening of the plane. Therefore, mandibule rotates lots. Of course, this rotation, then mandible becomes forward. Therefore, class 3 upon duration. Very simple. I show like this. This is black down. This is a class 1 growing, normally growing kid. But always cruiser plane and this OPMP, we call the OM angle. You know OM angle? And this is also a long time ago, 60 years ago, Texas guy, Dr. Schudy, published so many papers about cruiser plane. Then he measured the occlusal plane and mandibular plane, this angle. Okay? This angle is OM angle, he said. The occlusal plane, occlusomandibular plane angle. This angle, during the growth, this angle is not changed, he said. Always same angle, about the same. Something like 13, 14 degree. Okay? Almost no change. This is the age. Then if you compare the graphically growing subject, this occlusal plane, very much graphically, and OM angle is slowly increased. Why? I need to show you again. This kind of too much increased particle dimension, mandible want to adapt by rotation, but this increasing particle dimension is too much. Some degree a little bit open mandible. Then so open by the tendon. Therefore, OM angle is slightly increased. This is a difference. Okay. So, here, beautiful open by the sea. Open bite, we have many different types, different types of open bite. Yes, open bite is very, very difficult case to treat orthodontically, especially class 2 high-angle open bite. Always that type of the case joint problem. Okay? How about the class 3? Class 3 open. Oh, class 3 open is more easy case. I say the initial part of my lecture, class 3 open bite. But this kind of open bite, is it difficult to treat orthodontically? 30 years ago, I started in Vienna University. I went to orthodontic department. Professor Bantoleon is organizing orthodontic department. I asked during this, okay, here at your university, this kind of patient, if you have, what kind of treatment? I asked him. He said, maybe, no doubt, surgery. Yes. Open but surgery. Yeah. When I visit to Colombia and some orthodontic department people, I ask them question, and they say, no, this is a surgery. Surgical case. Well, like this. Why so difficult? Once again, I want to say this is the most easy case to treat orthodontically, not necessarily the surgery. Okay? If you do premolar extraction, okay, it's a difficult. I always push mistake. Okay. Here, this is the cases which I started orthodontic 3 years course in Vienna. Many from Italy, Germany, Spain, Portugal, many different countries orthodontists coming to me bring this kind of cases. This is all previously premolar, past premolar extraction cases. But once treated, the half year, 1 year later, again opened. Why? Once with premolar extraction, that means premolar extraction doesn't work to be open bite. So, even here, non-extraction cases, then after the orthodontic, first orthodontic treatment, but pretty soon again, until the bite is opening, even premolar non-extraction, but why open again? That means we are missing to remove etiology. Not treated, but still etiological factor there. Many people come trusting this kind of I know. But 50 years ago, many Orthodox textbooks say, oh, open Bible is supposed to buy tongue behavior. I don't think so. If tongue is problem, remove tongue. Yeah, you have to remove ideology back. Yeah, because if you see open Bible case, until Bible is open, 100% of until Bible open case, 100% they are tongue or forward and tongue clasping program. This is because until Bible is open. Therefore, people try to close this opening by tongue. I never do so-called master education type of approach. After open by close, then okay. Okay. Anyway, something missing. 1974, one paper published by Dr. Yang Kim. What he did was different malocclusion group, class 1, class 2, division 1, 2, and 3. Yeah, this is a number of the cases. He tried to find out what type of the malocclusion group show more open mind. Red bar, yeah. This is open mind. Class 3 people, but class 3 group, 83% of this group show anti-open mind. Why class 3 anti-open mind? See, of course, class 2 division 2 is no, right? Class 2 division 1, 4.5, let's say 5% of class 2 division 1 patient showing open. And class 1 group, well, 16%, not so many. Majority of the open by group here. But please understand correctly. Oh, class 2 division 1, open by, this is not so many, only 5%. No. Originally, all material, class 3 group is only 2.4% of class 3 and 83% open by. But here, about half of the malocclusion group is class 2 division 1, then this 5%, this is not a small, pretty big amount of class 2 division 1, so class 2. Now this is a big problem. But this is later and one case, in Japanese case, came to our department and well, the face showed something high-young, free tendency, and illusion like this, that's it's she did about 4 or 5 years ago. She did the orthodontic treatment in my city. also notice this case. Then, I don't know why. This lower first premolar removed. Why only lower premolar removed? What is the compensation? Okay, later I will ask you, what is the compensation? But unfortunately, orthodontist brain only think about anterior-posterior dimension. Therefore, this is class 3. Okay. Originally, this was class 3 case. Then, okay, lower premolar extraction maybe help something to correct the bite. No. She said, yes, this previous orthodontist treatment, I got bite once established biting upon teeth, but pretty soon, this lateral here opening, then this case, she go back to her original orthodontist. Well, I cannot bite this. Therefore, please correct this. This orthodontist said, no. You have something genetic problem. Therefore, we cannot treat. If you want to correct that, surgical orthodontics necessary. And she was so afraid. Why surgery? Then she came to our department like this. Then I made diagnosis and finally I don't like to reduce so much tooth material, but for some reason I removed this case upper 7, and lower 8, 4 molars. Because I will explain more detail, but all these are inclined forward, lower molars and ears, rounding. This is a big problem. Anyway, I removed, then only what I did, very simple. Lower is all the buccal segment inclined too much forward. Just I did upright. Very simple. Therefore, not so long time to remove. The uprighting, of course, not a perfect occlusion, because already molar extracted, and therefore, anyway, uprighted treatment, this was done, and this is the profile, but her profile also changed with ICD and before like this, then profile changed. That means this her mandible little bit adapt backward position. Very simple treatment. And let me show you one interesting case. This boy, he was 16, 17, 16 years old. them as so-called hemi-facial microsome. Okay? One side of is this side some defect of the ear joint also, no joint and ear joint. This ear is missing. Then he came. No joint here, no condyle. This side is okay, but no joint. And I'm going to make sure that also, here, condyle and rostrum, here, nothing. Then in Yokohama, we have a big medical school. Plastic surgery department. The Dr. Brown, treatment Brown, he needs, anyway, no joint. Therefore, we have to reconstruct a joint. But, you have a little problem with the bite. Therefore, you should treat biting situation first, then we can make a nice joint, metal joint. Then he came, like this. Usually, what do you think? One side of the joint or condyle missing. What happened? Losing. Of course, old philosophy. We also don't we discuss about the so-called growth center in the condyle. This is an intrinsic growth capacity that grows. Then mandible comes forward. This is an old concept. That means this side of the condyle missing. That means occlusion should be this side plus 2. What do you think? But if missing condyle this side, but the occlusion plus 3, what do you think? Condyle is not necessary to grow the mandible. Well, once again, I like to say, vertical dimension, occlusal plane, the mandible adapted by rotation, that's okay. No condyle. But then he's biting like this. Here, also free tendency, but and open bite, also open bite. I treated in very simple way, saying all these inclined buccal segments forward, just apply to establish the so-called occlusion support. Very nice support. Well, then I sent this case back to medical school. Then this doctor said, nice bite. Yes, I can chew everything. I took a chondrograph for him. Of course, this side we cannot take hinge axis and crazy movement, but chewing this kind of functional movement, no problem. Then, maybe you have a nice bite now. Therefore, not necessary to reconstruct the contact or join. They finish this case. See? Another case, this is not my case, in my city, one orthodontist practiced, he was graduate from our school. He one day wrote this case, 7 years ago. Okay? A little bit wonderful class 3 tendency, and occlusion like this. Okay? It's to it and to open tendency, but not so severe. I don't know. But this also don't try to do expansion or finger appliance, tincture, this kind of approach. But now this case, 18 years, very severe class 3 phase, condition like this. Open pipe means class 3 open pipe. This is a kind of family. Same etiology and same mechanism of growth of but now 18 years old already, this was really difficult. More early treatment is necessary, this kind of case. So anyway, he brought to me the cephalogram, 7 years old, 9, 11, 14, now 18 years old. Yeah, this kind of growth. This is a family. You can see this. Yeah, we have a big problem. This is a molar area crowding. And this is a tracing here, 7 years old. Look at this little thing. Big amount changing and flattening of the little thing. That means here erupted more. This makes flat occlusal frame, mandible, if I superimpose, see, this much increase partial dimension, but still mandible rotate forward, slightly open, because too much increase partial dimension, but the mandible try to adapt forward by rotation, but not enough. This one identified is open. So, another case, I show you this 12 years old boy. This case, 12 years old, fighting specimen, now 16 years old, but more severe, plus B, 5, here. Okay. Now 60 years old, I have cephalometric tracing here. Yes, originally 8 years old, occlusal frame okay, looks okay. But 12, 14, now 16 years old, very much flattening of the occlusal frame. Okay. Then I made a supine pose. Yeah, posterior part is come down, and but mandible try to adapt by rotation. This is another class 3 case development, always showing class 3 case, the posterior cruiser plane rapid. Yeah. So I feel that is the posterior part of cruiser plane. This is very big problem. And as I said before, if I go to United States, we saw this class 3 cases and treatment approach. American also one case. No, in United States, we don't have such a problem. You are Japan, therefore Asian country, only Asian country have this kind of problem. I got angry. Oh, then I did another research with a friend using the Caucasian sample. Okay, then the idea we use if you go to Canada, Toronto University, we have Burlington Growth Center. Okay? Then we try to use Caucasian growth sample to check what happened. User friend and mantle adaptation. Then we published this paper in American Journal of Physiology. We measure the different user friend. This is okay. Tanaka Midori Tanaka at that time belonged to my department. Then we did this research together. Okay, this result, okay, only this is a posterior occlusal plane. Posterior occlusal plane. Different inclination among different molecular groups. This is a class 1. Class 2 case showing very steep posterior occlusal plane. Class 3 case very flat, significantly flat occlusal plane. Yeah. This is the same result as Japanese people. This is a different way we measure upper occlusal plane posterior parts. Over here, they are significantly different among different groups. Anyway, then different age group we measure. Okay? 6, 7 years old up to 18, 20 years old. Slowly, you know. For example, class 3 people, this is a blue. Yeah, this is increasing. That means flattening of occlusal plane. Okay? And the class 2 group, more and more steep occlusal plane. Yeah. Especially after 10 years old, more and more changing and significance of difference. Usually this skeletal malocclusion group, when their skeletal is more getting worse, milk dentition days already possible? No, usually no. After 10 years old, more and more increased because more influencing molar area cloud. Therefore, I was so much interested with this factor for influencing occlusal plane. Why is occlusal plane such a pathologically flattening? See, this is an adult case. Class 3 skeletal, always class 3 people accompanying failure of open life. Yeah, this is crazy. Somebody dentist with the fantastic. But if you see the intraoral photo, see here, molar area is more erupted up, going eruption more. That means usually we have a curve of speed here, but this is a common symptom. Reverse the curve of speed. This is crazy, but see the cephalogram and molar crowding here. Let me show you another. This is a 20 years old boy playing very high angle, high mandibular play angle with a area open by and, here reverse curve of speed. This upper dentition, this is also a common symptom. Upper dentition clouding. This is a good sign to treat also good. Okay. So this case, such a high angle here, very flat occlusal plane. Then this is we try. Okay, why don't we remove this third molar? Then we remove. Then try to change the occlusal plane. Here, posterior part. Our target is here, not anterior open wide pocket. This case, well, this is a bad case. His oral hygiene is not good. 3 months, so he didn't appear this kind of problem. One day he came with this kind of situation, bad oral hygiene and some decalcification problems here. Then I stopped to continue breathing. But looks, this is before breastfeed and the open bite, but this is 5 years later. I finished like this, but looks correctable, right? This kind of class 3 and open bite. His oral hygiene was bad. time we realize, no, we can treat also don't fail this kind of thing. But this is also very interesting boy, a 13 years old boy. Sorry. Well, this is 13 years into the situation like this. Okay. 13 years old, until a crossbite, but with something 2-3 millimeter over 5. And only 13 years old, but still will be here and will slowly exchange half year later, 1 year. Yeah. Until a bite is open. Even here, milk teeth are gone, but bite is open. This is 2 years after from here. 2 years. Then perfect. Reverse cavity, lateral graphically, anterior open by a little bit of grounding, like that way. Hey. So if you see the harmony, yeah, it is 6 years more, but still, 7 is very much easy. 8. Look, very careful. This part. 6, 7, 8. Almost vertically aligned. 6, 7, 8. This way. This is crazy. Half year later, now this milk is on and start this premolar, the second start eruption. Then here, 6 and this number 6 is squeezing because not enough space. Therefore, start squeezing out of 6 years more. Upper 2, yeah, pushing down. Then here, the reverse curve of speed. Can you imagine what happened? Push. This pathological increasing partial dimension here, referendum change, deep, we have 2-3 millimeter over 5 and slowly increasing and area bite is opening and 1 year later, 2 years later. Yeah, something expansion here. Here's what? Perfect class 3 anterior open by established. Then I try to measure this much increase, only 2 years. Only 2 years. 6 years more, lower, total nearly 10 millimeter increase. Only 2 years. Therefore, this boy cannot adapt correctly. Little bit maldevelopment and opening, therefore open by leaf maldevelopment. This is the problem. And also, we have to understand this evolutionary. We have the peak. I mean, upper and lower jaw compressed until posteriorly very much. Therefore, we have no space here to erupt all the molar. Right? This is, I want to say, this is discrepancy in posterior part of dentition. I published this paper. One of the very important etiological factor is the posterior discrepancy. Okay? So, all the modern people are not enough space there. This is a 6 years old, 6 years molar erupted, 7 and 8 is growing here. Here, not enough space. If this is the skull of 8 to 8 whole dentition, totally full eruption case. We need this much space. Right? But usually we have no this much in the space. If we compare this way, okay, this is 6 years molar eruption, okay, very early mixed dentition stage. But this is a full eruption, fully erupted all the teeth. Anterior part and the posterior part, we have the same size, same anterior-posterior dimension. Right? But in your diagnosis, also go to the patient. So you have experience to calculate so-called discrepancy. Tweed recommend arch-length discrepancy or total discrepancy, whatever discrepancy, but you are always concerned about only anterior part. Here. No. This is not enough. We have to think about more posterior part. Because of influence very much in the tissue. Therefore, my idea of the posterior discrepancy is, here we have not enough space. This is a posterior discrepancy. Then this influence is not only anterior-posterior dimension, but also vertical dimension, molar over-eruption, or majorly inclined whole dentition. This is happening. We have to solve this problem prior to start orthodontic treatment. Please. So, well, we have to, of course, we have to think about anterior discrepancy, posterior discrepancy, all dentition, we have to have an idea of the discrepancy. This is the evolutionary problem. But too many in orthodontic education, too many teachers only talk about anterior part here. Therefore, I wanted to emphasize more important is here, posterior part. Therefore, I put name posterior discrepancy. Okay? maybe maybe they need a lunch break.
Yes.
Really? Really? Okay. So part of posterior discrepancy. This is the first paper in orthodontics. Is 1983, one paper published in the American Journal of Orthodontics in Norway. And I very close same group. Then we did some research in Japan at that time. 40 years ago, we have still some small village, countryside. Then, therefore, once a year, our group will take care of the especially kids. Only we can do milk dentition. Milk is if we have dental carriers moved, then next year. But this kind of 9 years old, every year we went there and this kind of approach. Then one whatever the reason, dental carriers or we remove this milk molar removed. And at that time, in Japan, then dentists, everybody talk about, early loss of the molar, what happens to this 6 years molar? Everybody say, no, this tooth migrating forward, then getting so-called early loss of this space. 6 years more move forward. Therefore, that time, crown roof, digital shoe type of just maintain this space. But we watch, this is really necessary approach. Then we did this kind of approach. Then we measure. Really, after early loss of milk molar, then what happened in the 6? Actually, if we remove milk teeth earlier, but 6 years molar, not migrating forward, just standing the same position. But if we have posterior, this is the one and okay. first paper published in AJO, which are explaining posterior discrepancy. Code. If we have a posterior discrepancy, okay. I cannot see. This is okay. Okay. Here, the strength deficiency in the posterior region seems to have a positive effect on the medial drift of the first molar. Medial migration of first molar seems to be pathologic rather than physiological, and strongly affected by posterior discrepancy. Okay? That means if we have a posterior discrepancy here, yes, this is migrating forward. But some kids congenitally missing 8, they are kids. No, they don't reach this thing molar forward, don't move. Therefore, actually this migrating forward is caused by posterior discrepancy, not the physiological. So that this paper is the first paper describing the posterior discrepancy. Okay? So then, okay, now lunch break time. Let me show you quickly. In my computer, I collected many places I did the courses. They bring their patients. So many also documentation. I collected so-called M3, wisdom teeth, source number 8, fully erupted teeth. What happens? Here, this is a 20 years old occlusion like this. All buccal segment implant. Here is very interesting. 2001, normally extending pretty soon. Here, milk is born and start migrating on this side forward. Then finally, class 3, case 20 years old boy, nearly fully erupted all the 8. Then class 3 anterior open. 18 years old lady, yes, this case, like clouding and little class 3 tendency, relation, anterior open by tendency. Another case, here, 5 years old, female, patient, here, eruption, because, the same, this is a two case, 42 years old lady came with this kind of blue eruption in anterior open by with very much joint degenerative change. This is a posterior discrepancy. Okay? Because, later this afternoon I will explain a little bit about, therefore, in my practice, I want to remove hard molar early age. 7, 8, 9 years old, we should start reading. Okay? So, do you have a question? I like to stop here. Then, okay. About 1 hour lunch